My name is Mike Krug. I'm a practicing general internist, formerly inpatient and outpatient, for the time being inpatient only. I'm a clinical associate professor of medicine with the University of Washington, and I'm currently the medical director for physician and APP education at the St. Luke's Health System. Formerly, I was an associate program director with the University of Washington's internal medicine residency program based in Boise. A structured approach to undifferentiated anemia is important in primary care today because it happens so frequently. You have to have just a regimented kind of answer to things and next steps set in your mind. You don't have enough time to sit and ruminate and think every time you face anemia. You have to have it locked in and regimented and set up. The other thing I would say is, at least in my community, the wait times for a hematologist for undifferentiated low to moderate risk anemia are very, very long. And so your patients are going to just trudge along for a long time. So if you as a generalist can march through the first, second, maybe even third steps in the workup, you can really catch a lot of diagnoses, make a lot of diagnoses yourself, pat yourself on your back a lot, and then at least set things up well so that all the basic stuff is covered and been addressed before they reach the hematologist to look for those zebras. I see a significant number of misconceptions in clinicians' approach to anemia. I would say the four biggest ones, briefly. Number one, people using serum iron to diagnose iron deficiency anemia instead of ferritin and percent saturation. Number two, not following up a borderline vitamin B12 level with a methylmalonic acid or just starting vitamin B12. Number three, failure to follow up new iron deficiency anemia diagnosis with EGD, colonoscopy, celiac disease testing. And finally, underuse of SPEP or serum free light chain testing in patients with undifferentiated anemia. My perspective is if you screw up any of those four, your patients are really going to suffer for it big time. And not only short term, but potentially long term, especially in the setting of vitamin B12 deficiency or failure to diagnose multiple myeloma. That can really cause some downstream trouble. So getting it right up front, you can majorly impact the trajectory of a patient's health if you get some of these right. The number one thing to ask about when you're facing a patient with anemia is bleeding. The number two thing to ask about is bleeding. That's a little joke there. But I think, bleeding is really important, especially taking a thorough menstrual history, not just saying, are your periods normal? Really getting into how much is coming out because it might be quite voluminous, but it might be normal to that patient. Also, some other less common sources of bleeding. Does a patient take NSAIDs? And so they're having occult bleeding that you're not seeing. They're not seeing melanoma or hematochezia, but NSAIDs can cause that. The other thing is, does the patient have a history of bariatric surgery, especially gastric bypass surgery? Those patients are much, much higher risk for micronutrient deficiencies. So your thresholds for testing and treating are much lower. And the last question that's important to ask is what type of diet they follow. And what I ask is, do you eat a varied diet that includes eggs, meat, vegetables, and citrus fruits? And if they do eat all those things, then they're much less likely to have a micronutrient deficiency in most clinical settings. If they eat a very restrictive diet that doesn't include those elements, then you might be much more suspicious for a nutrient deficiency. The essential labs in an anemia workup, if you ask 10 clinicians, you're going to get 10 different answers. But to me, the very bare bones is a CBC with differential, a reticulocyte count so you can calculate the index, and an iron panel including the ferritin. I think those are the very base. And I think the next level up is considering adding a vitamin B12 and a folate, especially if they have macrocytosis, and considering SPEP, serum-free light chains, especially if they have other symptoms or signs of something like multiple myeloma. And then finally, if the patient has labs suggestive of a hemolytic anemia, then you would do your hemolytic anemia labs like total bilirubin, LDH, haptoglobin, and a peripheral smear. Primary care clinicians should break down anemia probably looking at the reticulocyte count and reticulocyte index first. If it's low, it's hypoproliferative. If it's high, it's hyperproliferative. Most commonly, it's hypoproliferative or low. So if you're in that state, then you break it down by MCV. If the MCV is less than 80, then you're microcytic. You're thinking of iron deficiency, thalassemias, and a few rare things. If the MCV is between 80 and 100, normocytic, you're thinking of anemia of chronic inflammation, chronic kidney disease, multiple myeloma, and some other less common things. And then if you're macrocytic, if your MCV is over 100, then you're thinking of vitamin B12 deficiency, folate deficiency, liver disease, alcohol use, myelodysplastic syndrome. Those are the ones off the top of my head. And the other thing to note is sometimes you do get borderline cases where the MCV is 81 or something like this, or 98, things like this. And in that case, especially when you're talking about these cheap, commonly used, commonly interpreted lab tests, make sure you cover the ones on the borders as well, because you can have more than one process, and so you can address both causes of a borderline anemia. The number one thing I think clinicians should keep in mind when approaching anemia is that if you order a serum vitamin B12 level and it comes back borderline, please do not ignore that. Either follow it up with a MMA level and a homocysteine level, or just start empirically treating that patient with vitamin B12, because otherwise it will drift down, and then they're going to get anemia and then major neurologic problems. So for the cost of pennies per day, you can save someone major troubles downstream. So remember that your lab, when you order the lab, it may come up as blue or unremarkable, not bolded, whatever the EHR trick is in your institution, as indicative of not worthy of further perusal. But remember that if someone's B12 level is between 200 and 400, even if it doesn't come up as bolded in your EHR, that's borderline, and those patients should get follow-up investigation with MMA homocysteine or just empiric treatment. One more practical tip in regards to anemia is, you have to sort of assess how willing they are to return for follow-up labs, because if you've identified anemia and a patient lives next to your clinic or next to your lab and they can come as frequently as you want, great, then do it by the books. Do it stepwise, find the MCV, then do these tests. And if that's not revealing, order more tests, you can be stepwise. But if you have a patient who lives super rurally, or you don't think is willing or able to come back and see you over and over, then you might order a lot more labs up front to make sure you catch some of these diagnoses. So of course, you're tailoring how many tests you're ordering based on how often you can get your patients back. So for my patients who I don't think can or will come back, and I have one shot, I order the bulk of the workup right up front, because I really want to catch these high yield diagnoses that we can make a major impact on.